afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on preconception health, pregnancy outcomes, and care experiences among women with disabilities in Ontario. My name is Sarah Carsley. I'm the Applied Public Health Science Specialist in Healthy Growth and Development at PHO, and I have the pleasure of moderating today's session. Before we start with today's presentation, I'll mention a few housekeeping items. As you may have noticed, we have moved from Adobe Connect to Zoom webinars to host PHO Rounds. This was done to enhance the attendee experience and address the technical issues identified by previous attendees. If interested, you can let us know what you think and share any feedback you may have about your experience today through the evaluation that you'll receive following this session. An email will be sent to you all after the session. With the new Zoom platform, attendees have the ability to customize their own view. Please use the Q&A pod if you have any questions during the session. We will save questions until the end of the presentation. The chat pod has been disabled to limit any distraction during the presentation. If at any point during the session you experience any technical issues, please email events@oahpp.ca. I'd like to state that as the moderator of this session, I do not have any potential conflicts of interest to declare. So it is now my pleasure to introduce the speakers for today's presentation, Hilary Brown and Leslie Tarasoff. Hilary Brown is an assistant professor at the University of Toronto Scarborough and adjunct scientist at ICES and Women's College Hospital. Leslie Tarasoff is a postdoctoral fellow, a research fellow at the University of Toronto Scarborough and the Center for Addiction and Mental Health. And I will pass it now to Hilary.
Great, thank you very much for the introduction and for the opportunity to present today. All right, so no disclosures from Leslie Tarasoff or myself. So as we get started, I just want to begin by giving a couple of acknowledgements about the other people who are involved in this research on disability and pregnancy. This is a project that is supported by a National Institutes of Health research grant to myself and Dr. Yona Lunsky at the Center for Addiction and Mental Health. We're supported by a large group of co-investigators from a couple of institutions across Ontario, as well as some colleagues in the United States as well. And I think it's important also to mention that we are supported by a really involved and enthusiastic advisory committee that's comprised of individuals with lived experience of disability, health and social service providers, and policymakers as well. So this research is informed by our work with them. So just an overview of our learning objectives for today. We have a couple of pieces that we're hoping to cover. We're going to be talking to you about some evidence that we've generated from this project on the preconception health and pregnancy outcomes, as well as care experiences of women with disabilities in Ontario. And that includes some population-based data that I'll be presenting, as well as some qualitative work that Leslie will be presenting after me. As part of our discussion today, we hope to talk to you about the importance of developing and implementing tailored resources for women with disabilities around the time of pregnancy. So we'll be talking about some of the recommendations that's come out of this mixed methods research. And we're hoping also to talk a little bit about the roles that public health professionals may play in promoting the health of women with disabilities in the preconception and perinatal periods in order to improve their outcomes. So just a little bit of context to situate this research within the broader sort of service and research landscape. When we think about disability and reproductive aged women, about 12% of women of childbearing age has a physical disability impacting mobility, a sensory disability impacting hearing or vision, or an intellectual or developmental disability impacting cognition, as well as practical, social, and communication skills. So disability is quite common among women who may be thinking about having children. Now, historically, the reproductive healthcare needs have been largely overlooked for women with disabilities within the healthcare system. And that relates to a long history of institutional segregation of persons with disabilities, as well as a history of involuntary sterilization, both of which are really a result of eugenic practices from the past. Now, of course, in the last few decades, there have been major changes on this front. One landmark report in 2005 was from the World Health Organization, which called for better reproductive health care for women with disabilities. And the following year, the United Nations Convention on the Rights of Persons with Disabilities published a large document that included information on the protection of reproductive rights of persons with disabilities, including the right to bear children and to determine the timing and spacing of pregnancies, as well as the right to parent. However, even since this time, women with disabilities continue to report being underserved in reproductive healthcare settings. So that's sort of the basis for the research that we've been undertaking for the last couple of years. And as I mentioned, this research includes both a population-based component, where we're able to use healthcare data to understand health inequities at a population level, as well as a qualitative component where we directly interviewed people with disabilities as well as providers. So I'll be speaking about the population-based component. So in Ontario, we have the benefit of having large health administrative data sets available to us that include information on the healthcare encounters of all Ontario residents, which are stored in an anonymized and protected fashion at the Institute for Clinical Evaluative Sciences. These data include linked information on physician visits, on hospital admissions and emergency department visits, as well as some limited information on broader sociodemographic information. And all of these data are able to be linked with each other using a unique encrypted and coded identifier. And what's really unique about the healthcare data that we have in Ontario is that we're able to link individuals' health records across time to get a really good sense of what people's entire health history is like as long as they've been in Ontario. And we're also able to link maternal records with baby records, which enables us to look at the experiences of women as well as their offspring. So that's a really unique contribution that we're able to make based on the data that we have available to us in Ontario. So again, using the data for this entire population in the province of Ontario, the objectives of this population-based research was really to understand inequities in preconception health among women with and without disabilities, as well as to understand their pregnancy rates, their prenatal care access, as well as some information on perinatal outcomes, including both maternal and newborn outcomes. So before I get into that information in more detail, I just want to describe a little bit more the cohort that we were able to look at, just to give you a sense of the types of groups that we're talking about. So using information on births between 2003 and 2018, so about a 15-year period, we were able to identify pregnancies to about 200,000 women with disabilities in Ontario and compare them to 1.6 million women without disabilities. And the figure on the right-hand side here just gives you a sense of the types of disabilities that we looked at. So we looked at physical, sensory, and intellectual and developmental disabilities, as well as women who had multiple types of these disabilities. So within the physical disability group, what we're talking about here is musculoskeletal disorders as well as neurological disorders. So musculoskeletal disorders being examples like rheumatoid arthritis, neurological disorders, things like multiple sclerosis. We also looked at permanent injuries like spinal cord injuries and congenital anomalies like spina bifida. In our sensory disability group, we were able to look at women who had hearing loss as well as vision loss. And in our intellectual and developmental disability group, we were able to look at women with autism, as well as those with various forms of intellectual disabilities. So things like Down syndrome, as well as fetal alcohol spectrum disorder. And then of course, we have women who may have more than one type of these disabilities, so physical and sensory, for example. So the first set of disparities that we looked at related to preconception health. And what this looks at is really an understanding of the health and social circumstances that people experience prior to pregnancy. So what is their health status like in the period leading up to pregnancy, which can be an important predictor for the pregnancy outcomes that we're looking at. We looked at a number of different indicators as available to us in the population-based data. We looked broadly at social indicators like neighborhood level income quintile. We looked at physical health conditions like diabetes and heart disease. We looked at mental illness and substance use disorders, medication use, and then experience of assault and other forms of violence. So there's a lot of data to think about here. So we've just summarized a couple of the take-home messages across the disability groups. And what we really did see is that across all of the disabilities that we looked at, there were very marked disparities of preconception health across those groups compared to women without disabilities. The notable disparities that sort of stood out as being the most important and the most notable were chronic disease, mental illness, use of potentially teratogenic medications, which is medications which can cause birth defects, as well as a history of experiencing assault. And these were elevated in all disability groups compared to women without disabilities. Also notable was the finding that the disparities tended to be greatest for women with intellectual and developmental disabilities across all of these indicators. So that gives us a sense of where some high-risk groups may exist. We also really wanted to be able to understand pregnancy rates at a population level, because one question we often get is how common pregnancy might be among women with disabilities. And so this is a figure looking at pregnancy rates in Ontario over the last 15 years or so. And the dark black line, the solid black line at the top, is the pregnancy rate in women without disabilities over time. And as you can see, the pregnancy rate sort of remains somewhat steady, maybe even decreases a little bit in the most recent years. And the colored lines below that relate to the 4 different disability groups that we looked at. And I'll just point out that for the sensory disability group in light green and the multiple disability group in the gray, what we do see is a small but significant increase in pregnancy rates across time in these groups. And in fact, in Ontario in 2017, about 1 in 8 pregnancies are to women with some form of disability in the province. So it's not a small group, and really demonstrates the importance of understanding reproductive health in this population. So that's the overall pregnancy rate. And on this slide, this is just a snapshot of one of our findings related to age-specific pregnancy rates. We really wanted to be able to understand whether there was variation depending on the age groups that we looked at. And this is the pregnancy rate specifically in 15 to 19-year-olds, which stood out as being different compared to the overall pregnancy rate. Although the overall pregnancy rates were somewhat lower in women with disabilities compared to their peers, in fact, what you see here is that the adolescent pregnancy rate in all disability groups is higher in women with disabilities compared to those without, with women without disabilities being the black bar and women with disabilities in the colored bar. So again, a group to pay attention to in terms of improving supports related to sexual and reproductive health care. Next, we looked at prenatal care access, and this was work led by a master's student, a master's of public health student working with us, who looked at an indicator called prenatal care adequacy, which looks at the timing of prenatal care access, as well as the overall number of prenatal care visits which are received relative to what is recommended by the Society of Obstetricians and Gynecologists of Canada. And so, I know this figure is a little bit busy, but if you look at the bars here, what we see is intensive prenatal care being the darkest part of the bars, showing people receiving more than the recommended number of visits, and then adequate prenatal care being the second darkest, blue right below that, which is people receiving the number of prenatal care visits that is recommended. And then the lighter colors relating to receiving less than the recommended number of visits, so inadequate or no prenatal care. And what you see if you look across these bars is that overall, it looks like most women in Ontario, regardless of the type of disability that they have, most are receiving adequate or intensive prenatal care. But there are some important disparities to note, and one of those is that women with intellectual and developmental disabilities are slightly less likely to receive adequate or intensive prenatal care than their peers, and therefore more likely to receive inadequate prenatal care. So again, just a clue about a population that could receive more support in terms of accessing the healthcare system around the time of pregnancy. And then getting into the perinatal outcomes, we also looked at outcomes in mothers around the time of pregnancy. And we looked at a number of different indicators that are commonly tracked in Canada by the Canadian Perinatal Surveillance System, The first indicator on the far left of the graph is severe maternal morbidity or mortality, which is an indicator of life-threatening pregnancy complications or death within pregnancy or the first 6 weeks postpartum. And for all of these outcomes, just to orient you to the graph, what we're looking at is outcomes for women without disabilities in the black bar, and again, the different disability groups in the colored bars across the graph there. And so what we see is that, overall, poor outcomes like severe maternal morbidity or mortality are rare overall, which is a good finding to see, but they are elevated in each of the disability groups compared to women without disabilities. We also looked at hospital admissions in the postpartum period, again, recognizing that this is an important period of transition for women when they could potentially benefit from greater supports. And again, what we see is higher rates of non-psychiatric hospitalization in women with disabilities compared to those without, and similar for the psychiatric hospitalizations, with much higher rates of psychiatric hospitalizations among women with intellectual and developmental disabilities and those with multiple disabilities compared to women without disabilities. Just to keep things sort of simple, we won't show the findings for the other outcomes that we looked at, but just to note that we did look at complications like gestational diabetes, gestational hypertension, and cesarean delivery. And these outcomes were more common in women with disabilities compared to those without, although the differences between groups weren't quite as large as what you see in the outcomes that we show on the slide here. Similar findings for newborns. So again, we looked at a number of different indicators that tend to be tracked by our perinatal surveillance systems in Canada, including preterm birth, small for gestational age, and neonatal morbidity, which are shown on the figure here. And again, what we see is slightly greater risks for these outcomes among women with disabilities compared to those without, regardless of the type of disability. And again, we looked at a number of different indicators, including neonatal intensive care unit admission, neonatal abstinence syndrome, congenital anomalies, and neonatal mortality. And the findings were similar to what you see in the figures here in terms of greater risks among the different groups with disabilities. So I just want to comment a little bit on some considerations to keep in mind when interpreting these data. One sort of limitation of our health administrative data in Ontario is that when we measure disability, we really are limited to using a medical diagnosis as available in the healthcare record. And so what this means is that we really are relying on sort of a medical model of disability, which relies on diagnoses, as opposed to the more commonly accepted social model of disability, which would rely on self-reportive activity limitations and participation restrictions and environmental barriers. So I think that's really important to note in the interpretation here, that we may miss women who feel that they have a disability but don't necessarily have a diagnosis to go along with it. It also means that we miss women who have a diagnosis but don't necessarily seek healthcare for that diagnosis, and so it may not be recorded in their healthcare record. But in Ontario, at least at this point, this is our best option for measuring disability and pregnancy outcomes at a population level. And hopefully that will change as more types of data become available through surveys and that sort of thing. We also had a limited ability to account for other factors that could impact outcomes. In all of our modeling, we do account for pre-existing health conditions, mental illness, and neighborhood level socioeconomic status. And those risks that I described do remain after accounting for those factors. But we do have a limited ability to account for other pieces like individual level socioeconomic status. We're also not able to look at sort of the intersection of disability with experiences of racism, which is important to look at. And we also don't have any information on health behaviors like smoking and that sort of thing, which could impact results. But with those considerations in mind, I think sort of the take-home messages from this part of the study are the following. We know that pregnancy is not uncommon in women with disabilities, showing really the importance of understanding reproductive health care in this group. We have clear evidence of significant disparities related to preconception health among women with disabilities compared to their peers. We also have some evidence of barriers to accessing prenatal care, especially for women with intellectual and developmental disabilities. And I think an important follow-up for this piece of the study is to understand not only the amount of healthcare that women receive, but also the quality of that healthcare. And Leslie will get into that in her part of the presentation. And then finally, we do observe higher rates of maternal and neonatal complications among women with disabilities, which are partly, but not completely explained by the preconception health disparities that I described. And so again, some data to really prompt us to dig into the experiences of women with disabilities that could inform exactly what is going on. And so I will turn it over to Leslie.
Thanks, Hillary. So really, Hillary set me up really well. So in addition to looking at population-based data in Ontario to really provide context to some of the healthcare outcomes data that we identified, we also conducted qualitative interviews to learn more about the perinatal care experience. Next slide. So as Hillary mentioned, our approach to specifically the qualitative part of the study was really informed by our advisory committee, who included women and some mothers with varying types of disabilities, as well as healthcare providers, researchers, and policymakers. So we conducted interviews both with people with a range of disabilities who had given birth in the last 5 years. And here, going forward, I use the language of people because there were 2 participants who identified as trans or non-binary, so just to be inclusive of and respect their identities. And then we also interviewed health and social service providers across the province. Next slide. So in total, we interviewed 31 people with physical, sensory, and intellectual and developmental disabilities. And these interviews were conducted by myself and peer researchers, so 2 women with disabilities also conducted the interviews with me. And the interviews focused on the services and supports that people access during pregnancy, labor, delivery, and the first few months postpartum. We asked people what they liked and what they did not like about the services and supports they received, as well as what they found helpful or not helpful. And finally, we had them comment on, what would make their care experience better. And just before I get into the demographics of the participants with disabilities, I'm not going to talk too much about the providers because we're still deep in the data analysis for the providers, but I'll just let you know that we also interviewed 31 health and social service providers as well as decision makers across Ontario. And within that group of 31, 18 were providers, and that included a number of physicians, so some obstetricians, some family physicians, 2 nurse practitioners, 6 nurses, including some public health nurses, a few midwives, and a few other types of providers like social workers. And when we asked them if they had received any disability-related training, only 10 of the 18 providers and only one of, and including in that, only one of the nurses indicated that they received any disability-related training and education. And for a number of those 10, the only sort of disability-related training or education that they received was completing the online module for the Accessibility for Ontarians with Disability Act, or the AODA. So there's a real lack in education among providers, and many of those providers who work with women and people with disabilities had really learned about this population and disability along the way, and recognizing a need in their community. So they didn't necessarily come in with a lot of training around disability. So here we just have a breakdown of the people that we interviewed. So again, about half, or just under half, were those that had a physical disability only, and that included things like cerebral palsy, multiple sclerosis, muscular dystrophy, rheumatoid arthritis, and spinal cord injury. We also interviewed 7 people with sensory disabilities only, so that included individuals who were deaf or had hearing loss, as well as those who were blind. 6 participants with intellectual, and/or developmental disability only. So that included people who self-identified as having autism, fetal alcohol spectrum disorder, mild intellectual disability, and cognitive delay. And then there were 4 participants who had identified as having more than one disability. About 2/3 of participants used an assistive device or communication aid. Most identified as heterosexual and were married or in a common law relationship. About 1/3 identified as white. 13 had an education level of high school or less, and this was predominantly those with intellectual or developmental disabilities and those with multiple disabilities. And about 2/3 had an obstetrician as their primary perinatal care provider, and 29 of the 31 had their most recent, and this is, I should say, their most recent pregnancy and birth had an obstetrician, and 29 of the 31 delivered in a hospital setting. So there were 2 participants who had midwives and had home deliveries, and there were a few others that had shared care and had a family doctor or a midwife delivery in a hospital. So we asked participants in the interviews if one of the services that they accessed while they were pregnant were any sort of prenatal education, and 21 of 31 participants indicated that they did access some sort of prenatal education, whether it be online or in person, or maybe a short course in a hospital. However, when asking about this type of service during pregnancy, many commented how these classes or courses around prenatal education were not accessible in terms of physical accessibility. And a number of the participants who were deaf talked about how there was no meeting their communication access needs. So this often meant there was no ASL interpreter. And then people, specifically those with physical disabilities, talked about how prenatal education was not tailored either to their disability or to their experience of having a quote unquote high-risk pregnancy and delivery. Next. So here I have some quotes from a number of participants, and I should say before I jumped into these qualitative results that we have mountains of data, and there's definitely data that's more relevant to obstetricians or midwives or different providers that women and people with disabilities encounter throughout the perinatal period. But here I thought I would pull some quotes that I believe would be relevant to those working in health promotion or prenatal education or public health nurses, so more of a public health focus here. So we know that women who are pregnant, including those who have disabilities, might engage in prenatal education throughout pregnancy, as well as engage in programs, public health programs in the postpartum period. So I tried to pull some quotes relevant to those areas of care and those types of providers. So this is a quote from a participant who is deaf, basically talking about how childbirth education class was not accessible. So because there weren't interpreters available, they ultimately couldn't access these services like other people would have to access. And they felt that if they were able to access this service, maybe they would have been a bit more prepared with pregnancy and taking care of their newborn. Next. And here's a quote from a participant with a physical disability who knew because of their disability that they would have to have a cesarean delivery. So they felt like prenatal classes were not tailored or relevant to them because there was a real focus on quote unquote natural vaginal births and quote unquote healthy people and healthy babies. And it just didn't seem like somewhere they would fit in, or it felt like they would get relevant information from attending. So they just didn't bother accessing that type of service. Next slide. So those are some experiences concerning pregnancy, but one overall finding we found in the qualitative data is there's a real lack of postpartum and early parenting support for women and people with disabilities. So a number of participants did share that they accessed services like Healthy Babies or Healthy Children or equivalent program in their community. Sometimes this was, more extensive participation or involvement with these providers and programs, but sometimes it was just one call or visit. However, generally in the postpartum period, most participants felt that services and supports were not accessible, and they encountered providers who seemed to have limited disability-related training or experience working with moms or parents with disabilities. Next slide. So this is a quote from one participant in particular with a physical disability who did have a positive experience with a public health home visitor program for 6 months postpartum. And she had to really fight to get this support for that long. So ultimately she felt like maybe she didn't need it for that long, but she found, being a new mom at home by herself when her partner was back at work, it was helpful to have this sort of support. But she understood how many other women and parents with disabilities might be hesitant to reach out for these types of supports because of poor experiences or fear of poor experiences, and particularly concerns about involvement with child protection services. So this was a real fear for many participants, and we know that a number of participants in our study did have current or previous involvement with CAS, so they were hesitant to reach out for supports during the postpartum and early parenting period. So this is a longer quote, and this speaks to mental health and a number of issues that participants with disabilities discuss, but really the pressure of, if a public health nurse or home visitor is coming to your home and how stressful that could be. So, they're coming, we have to clean up the house. We have to present this pretty picture that everything was going to be fine. But again, having sort of these fears about, CAS involvement, what is safe for me to talk about? Can I express my concerns without being judged that I have a disability? So a real desire for clarity and understanding from providers about disability and supporting disability instead of maybe making people with disabilities feel like they can't share if they're struggling, because that might, flag a provider to contact CAS. Next slide. And so a number of participants talked about how, they did have a public health nurse or home visitor come to their home, but often when that person did come to their home, that person did not have experience working with someone with a disability before. So this participant who was blind talked about how they really had to sort of teach the home visitor about blindness and about working with people with disabilities. So it wasn't really very effective or beneficial visit necessarily for the participant because they had to do a lot of teaching and there wasn't a lot of support around their disability. And again, other participants talked about declining public health nurse visits because of their disability and a fear of lack of understanding on the nurses or home visitors' part. So they were afraid of disclosing any challenges that they had or feared that they would be judged if, or judged because of their disability. So next slide. And then again, this speaks to the inaccessibility of postpartum and parenting support programs and services. So a participant with physical disability commented, even the services that they did send me, there was no awareness of disability. All the moms groups were not really accessible. It was awkward that I had to bring my attendant with me and I couldn't sit on the ground and do the things. It was awkward. And then sometimes the coordinators are awkward and they're like, you can park here, trying to manage you. So participants with physical disability talked about this quite a fair bit, how, there's so much encouragement, get out of your house, you're a new mom, build community, make friends, get social support. But if these programs and supports aren't accessible for you, you might avoid accessing them or feel really awkward and out of place when you're there, when you're the only disabled parent. And the people running the groups or other people in the groups don't really understand your disability and how to maybe treat you or accommodate your accessibility needs. So just a few things to consider with our qualitative data. So I think most people know or who are familiar with research that qualitative data is not meant to be representative of a population. So we did only interview 31 people with disabilities who had given birth in the last 5 years across the province, but we only did have a few participants who were blind. So there was only 2 of the 31 participants who were blind. And we had a hard time recruiting participants from Western Ontario, but we do know from some research done by some colleagues that there definitely are people with disabilities in that part of the province. And I really highlighted here some of the negative experiences and barriers and challenges that people encountered. And that was definitely predominant in the data, but there were some participants who shared positive experiences like public health nurses and other providers who went out of their way to support them. So for example, there was one participant who was blind who talked about a home visitor who was really helpful and, tactically, gave a hands-on demonstration and showed them, how to put a diaper on, here, touch this flap and do this. So really attending to the person with disabilities needs instead of, just providing a verbal explanation and they're like, you're on your own. So providers who seem to have more understanding about disability and really tailor their support to people with disabilities needs, those people tended to have more positive experiences and have, I guess, nicer things to say about the providers that they work with. So just quickly, I just want to run through some overall findings of the larger qualitative data set. So some of these things I already highlighted, more specifically to public health or things in the postpartum period, but generally many participants, and particularly those with intellectual and developmental disabilities, had a fear of disability stigma and discrimination and negative attitudes from providers. So many of these participants were hesitant to disclose their disability to providers for fear of mistreatment or involvement with CAS. Both among participants with disabilities as well as the providers that we interviewed, there was a recognition that there's a lack of disability-related training among providers. So this is definitely an area that needs work and intervention. Many participants talked about inaccessible care settings and services throughout the perinatal period, and that included physical inaccessibility, but also, especially those with sensory disabilities, unmet communication access needs. So many participants who were deaf or had hearing loss really had to advocate to get ASL interpreters themselves. Participants with physical disabilities also talked about the lack of coordinated care. So maybe their rheumatologist not communicating with their obstetrician or vice versa. So often having to coordinate care between different types of providers when really that should be happening at the provider level. The patient or participant shouldn't have to, advocate for coordinated care. And then finally, we identified a number of gaps in postpartum care which I think is somewhat ironic in a way. So many participants, especially those with physical disabilities, were treated as quote unquote high risk or closely monitored and given a lot of support during pregnancy, but their need for support was not really considered, or supports were not available in the postpartum period. So for many participants, and I think just generally this might apply to all women in the postpartum period, but it seems particularly heightened for those with disabilities, that there aren't a lot of supports and services available to support them in the postpartum period. And participants specifically talked about a lack of mental health related services. And I think this links back to some of the earlier quotes about fears of disclosing challenges when you have a disability, because you might be judged more harshly. And then a number of participants talked about breastfeeding challenges. So in some cases, a real pressure to breastfeed, but not a lot of tailored support around breastfeeding and disability. So now I'm just going to conclude, hopefully I'll go quickly because I'm looking at the time, with just some recommendations to improve clinical care based on our findings. So this is a recommendation from a participant with intellectual disability, and I think this can be applied to all disability populations and even those without disabilities, but I think really listening to the patient or client is really important, and people with disabilities, feel isolated and marginalized in many ways. So thinking about better ways to support people with disabilities, taking more time for appointments, asking people, what they need, what resources would be helpful, someone to talk to and not so rushy. And this is a quote from a participant who is deaf. And again, as I mentioned, many participants who are deaf talked about the challenges in having an ASL interpreter present throughout their perinatal period, but particularly in labor and delivery and those, first few days in the hospital postpartum. That was really important, and something that wasn't always a need that wasn't always met. So this participant talked about the importance of interpreters, not just for themselves as a patient, but the importance of interpreters for healthcare providers. So the interpreter is really for them, the healthcare provider, not me. During pregnancy, if a baby has a heart problem, they bring in a cardiologist to focus on that problem. So the interpreter is the same thing. Getting the interpreter in the first place so you're preventing any of the miscommunications and misunderstandings that could happen in the future. And we definitely saw in our data from people's experiences that not having an interpreter seemed to have real social and health implications for parents, and also potentially for their newborns when things weren't communicated or there was miscommunication about care plans or what was going on and decisions that were made. And this quote relates to the lack of mental health support. So this person with a physical disability talked about how it'd be helpful to have more mental health support for people with disabilities, and also more peer support. So support from other people with disabilities, because many people with disabilities do feel isolated and there aren't very many resources in their communities, particularly those who live in smaller communities. And many of the people that we did interview didn't know another mom or person or a parent with a disability. So people really looked for peer support. So just in terms of, I think, most relevant to many of you listening and to public health, a recommendation is to really take a life course approach to reproductive health care for women and people with disabilities. So this means, making sure people with disabilities are included in sexual health education and reproductive health education and preconception care. And this includes having discussions about reproductive life plans at an earlier stage. So conversations, when women with disabilities are in their teens, and we saw, again, the pregnancy rates that Hillary showed that the rates are higher among those with disabilities age 15 to 19 in Ontario compared to those that aren't. So really having these discussions earlier, if you have a disability, do you want to have children one day? When might that be? Let's make a plan around that in terms of contraception or things we might need to think about your disability. And also, again, more support across the first year postpartum and a focus on interconception health as well. So Hillary, a number of years ago, published a study specifically on women with intellectual and developmental disabilities in Ontario and found that they had higher rates of shorter sort of between pregnancy, and Hillary can jump in and fix me here, but having pregnancies shortly after one another. And, that's generally not recommended, but we know that this is something that some women with disabilities experience. So the importance of, reproductive life planning and discussions about contraception, these are all really important for this population. Another recommendation, and I think this is pretty obvious, is there's a definite need for disability-related training of public health nurses and home visitors and, perinatal providers across the board. And one participant talked about, it'd be great if in, creating these trainings that we also included people with disabilities so they could, share their lived experience in creating these interventions or trainings. So I think we just have two or three more slides to go. Just some other sort of practical recommendations. It's definitely important to have or to adapt resources to meet the diverse learning, communication, sensory needs and concerns of people with disabilities. So this could mean utilizing technology, making sure interpreters aren't available. And we know that, they're not always available in every community. So maybe, that's somewhere that technology can be utilized to have, an interpreter over Zoom or something like that. More detailed explanations and hands-on demonstrations. So I think I might have mentioned this participant before, but she talked about how when she did take a childbirth education class, the teacher was really great and accommodating. She let her feel the models of pelvises and things like that, asked to be oriented to the space. So this person, leading that childbirth class is really accommodating and attentive to the needs of this person who was blind. And then finally, again, more sort of practical recommendations. So for some people with disabilities, longer and more frequent appointments and visits would be helpful, home visits if possible. And I think especially in the postpartum period would be really helpful for many people with disabilities. Importantly, and this relates to sort of the life course perspective on reproductive health, but to work proactively together with people with disabilities and their support persons as necessary or applicable to ensure that resources and supports are in place before, during, and after pregnancy. And I think when I say resources and supports, I mean those related to disability, but I think for many women with disabilities, specifically those with intellectual and developmental disabilities, we need to think more broadly about the resources and supports they may need. So maybe resources or supports around housing and other things to make sure they're in a good place before baby comes. And then finally, and most importantly, asking people with disabilities what works for them, what makes them comfortable, what do they already do that works, or what are the things that they need? So really engaging with people with disabilities versus assuming, what we think they might need. So here is just a list of resources where we have some of our published papers and some local resources here in Toronto, a resource for a research center for some of our colleagues in the US who do some similar work. And I can share the links to all of these in the chat if that's helpful. And I think the slides will be shared. And then we just want to say a big thank you to our large research team and advisory committee. And you can see photos of some of them here. So you can see there's, quite a diverse group that we have. And we're really grateful, especially to have those with lived experience informing this work. So thank you so much for listening.
Thank you both. That was beautifully presented, and this is such important work. So I just want to say thank you on behalf of PHO for presenting to us today. And I'd like to invite everyone on the line right now to enter your questions into the Q&A chat pod. And while we're waiting for you to ask questions, I have a few of my own. First question I have is more of a methods question to Hillary about your ICES data. For the preconception and prenatal classes or care, was that through OHIP billing codes, or what, or I should just say, what data sources were that from specifically?
Great question. Yeah, and I think I know what you're getting at. So yes, we used physician billing codes to capture information on prenatal care use. So unfortunately, that means that we only capture care with a family physician, obstetrician, or other type of physician. And so we don't have information on receipt of midwifery care. But that's something we're hoping to look at in the future with another data set born, which does give us information on midwife access as well. Mm-hmm.
Okay, awesome. Yeah, my next question was about the quality of the coding data. Just in wondering if it could be used, as other indicators for public health units.
The quality of which data, sorry?
The coding data, like as you mentioned, the how physicians code and again,
right.
Leslie got into this a little bit of like, we know that they had the visit based on the code sometimes. Mm-hmm. What was actually done in the visit? Is there any plans to do work on that?
Yeah, that's a really great point as well. So yes, so with our physician billing codes, we're able to determine when someone first received prenatal care during their pregnancy. So whether that was in the first trimester as recommended or later. We also know the total number of physician-based prenatal care visits that they have. But like you said, we don't have information on the length of the visit, the quality of the visit, how the person felt their interaction with the healthcare provider went. And so I think that's why it's so important to have the qualitative component to this study, because the interviews that Leslie and the peer researchers did, they're able to dig into some of those interaction pieces. But certainly from a sort of population level disparity perspective, the population-based data give us numbers to start with, and then we can dig into them more with other types of data.
Thanks so much. I'm looking at our Q&A. We don't have any questions at the moment. So please, if anyone, I think you did such a good job presenting that you hit all the bases. I was actually thrilled that some of your qualitative participants had some interaction with our Healthy Babies, Healthy Children home visiting program. Because as you were presenting, Hillary, I was being like, are they seeing HBHC? NFP is the one that some health units provide for younger moms and younger people who are pregnant. So I'm thrilled that you have some of the data to, make all those excellent recommendations at the end. I see a question coming in from Hiltrud Dawson. Here at Health Nexus, we have been working with Hillary, Leslie, and a couple of other experts on developing a childbirth support tool for people with disabilities. The resource is intended for a person to fill in checkboxes for a number of areas, and this will help the service provider understand how to support them. That's excellent. I didn't know that was going on. So thank you for sharing, Hiltrud. Another question is, thank you so much for this research. I'm a midwife who works in a community health center, and we record end codes for every encounter that we have with clients, just like the MDs in our clinic. For salaried providers at CHCs, did you have end code data or only for MDs billing through OHIP?
Yes, and that's exactly the limitation that we were hinting at with the response to Sarah's question. So when providers are salary-based, it's more difficult to determine on our end with this large administrative data set sort of what the visit was for. And so we only have the OHIP billing codes available to us to determine prenatal care. Now, again, with born data, which is, as many of you know, a clinical registry that contains more detailed information on midwifery and physician visits as well, we will be able to dig into that more. So that is definitely something we're hoping to look at. Yeah, and that would include community health centers and that sort of thing. Yeah.
Excellent. So another question or follow-up is, it would be interesting to look at CHEs because we capture details for each visit. And yes, born would be great to look at. So yeah, that would be excellent next step. Next question is, can the switch to virtual care potentially capture more of the individuals who traditionally may have not sought help resources that would allow them to be diagnosed or supported? Great question.
That is a great question. I'll comment quickly and then turn it over to Leslie because I'm sure you have some thoughts based on the interviews. But I mean, it's something that we've been thinking about a lot during COVID because so much care has gone virtual. And I think certainly in terms of distance and physical accessibility, anything that can be done remotely is helpful for a lot of people. But on the other hand, there's also communication challenges with some remote types of care, particularly for women with intellectual and developmental disabilities, and perhaps those with sensory disabilities as well, depending on the nature of the virtual care. So I think there's lots of opportunities, but some challenges that will also need to be considered depending on women's needs. Leslie, do you want to comment on that as well?
Yeah, I don't think I have much to add. I agree with that for some, and I think in the postpartum period, maybe having more virtual visits, follow-up support would be great, but during pregnancy, depending on the person's needs and their, like communication challenges and things like in-person visits, I think would, be great. But I think in the postpartum period, maybe that's, we can't always get people home visits to people's homes. And, especially if people have more than one child and they have to pack up and, lug multiple children to appointments and things, if there can be more virtual visits in the postpartum period, I think that would be really helpful for a lot of women with disabilities.
And just to add on to that, I think in this new era of virtual service delivery, especially from the public health perspective, we're really looking like there's not a one or the other version. It can be a hybrid model, and it can be what the client wants, right? Like, as you said, asking them what would be the best for their needs might be the answer to whether they do virtual or in person. So thank you for that answer. I have one last question. No, actually, I have two questions. First one is, do you think you'll be looking at other childhood outcomes, like later past the perinatal period?
Yes. So we have some CIHR funding to follow up kids over time, because I think we did a review on this earlier, Leslie and myself, looking at prior research from the US and that sort of thing. And it really shows, moms have barriers accessing healthcare, and therefore the barriers also tend to extend to their children as well for lots of different social reasons. And other sort of challenges. So yeah, we'll be extending the cohort to look long-term at children's healthcare access, as well as moms, years after pregnancy and sort of the interconception period and that sort of thing. Yeah.
Thank you. I have a comment from Hiltrud. Thank you for an excellent presentation. My big take-home message is that 1 in 8 pregnancies are complicated by disabilities, making this a really underserved population. Let's see how we can change that.
Great comment.
Thank you, Hiltrud. And I guess one last question from me again. On that note, you've made some really great recommendations to clinical care providers, but if you can make one recommendation, let's say to policymakers or decision makers at kind of the systemic level, what do you think they should be tackling first to, reduce some of these disparities?
I can jump in with one quick thought, and then I'm sure Leslie has some thoughts too, but I would say disability-related training for healthcare providers. We hear often from physicians that is just not a part of their medical training, for example. And I think if this is a population that's, represented among obstetric groups, then it needs to be a population that people receive training on.
Yeah, my answer would be the same. So definitely interventions, educating and training providers, and even educating policymakers and people who coordinate and organize and plan, healthy babies, healthy children, and other programs. Because really, when I, did the interviews with those in decision-making roles, including some in different provincial ministries and programs, most of them, this population, disability and pregnancy or early parenthood wasn't on their radar. So those interviews are not very rich. Those with the service providers who had experience working with women with disabilities, you know, they had a lot of great things to say, but the decision makers, this population isn't really on their radar. So I think, like was mentioned, you know, the finding that 1 in 8 pregnancies is to a woman with disability in Ontario, that's really significant, and really, we don't know what that number is across Canada. We don't have population-based data on, you know, pregnancy rates, pregnancy outcomes across Canada. So we're kind of in a really exciting spot having more and more data here in Ontario, but kind of across Canada, we need more messaging and awareness that this isn't a small reproductive population. We need to pay attention to them. And I think really educating, you know, trainees, you know, medical students, nurses, and then, you know, when they're practicing, to educating them more about disability. And this is just sort of my plug about the failure, I think a little bit of equity and anti-oppression and diversity training in medical school and other medical provider, service provider type programs. You know, you have your day or your week focus on diversity, you talk about sexual orientation, gender identity, more and more about anti-Black racism, Indigenous populations, but disability is often not included. So that's sort of my plug and my push that we need more disability-related education.
Thank you so much. So I'm looking at the time, and it looks like we're at 1:01. So as we wrap up today's PHO round session, I'd like to thank Hillary and Leslie for presenting. I'd also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare professionals. To access past PHO presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Lastly, you can expect to receive the brief and anonymous PHO round survey for today's session shortly. Please try to complete this to help us improve our programming. And thank you, and have a wonderful day.